are back on the Zero Hour. I'm your host, Richard RJ Eskow. Diane Archer is one of the smartest people I know, especially about healthcare and health policy. She recently wrote and published an open letter to the Secretary of Health and Human Services, Javier Becerra, and Administrator Brooks Schur of the whatever you call it,
Insurers for Medicare and Medicaid Services.
Yeah, yes, right. I was trying to remember the acronym, and she's also a good friend. And what she wrote under the headline 10 Ways to Improve Medicare Advantage, which you can find at Just Care USA, was in response to open comment period, and it is a terrific overview of the situation with these private insurance plans known as Medicare Advantage. So I asked her to come on and tell us about it. So without any further ado, Diane Archer, thanks for coming back on the program.
Total pleasure, Richard.
Well, listen, as I said, I thought this letter was terrific. You and I have talked many times privately and on the air as well about Medicare Advantage and basically the concern that the idea of allowing private insurers to administer Medicare is kind of letting whatever the expression is, the wolf put its nose under the door or whatever, that it's kind of corrosive to what Medicare is all about. But I thought you did a terrific thing here, which is, Medicare Advantage is very popular in Washington, D.C. for all sorts of reasons, but even though it is harmful to people who don't realize what they're getting into when they sign up for it. But the Secretary of HHS and the Administrator, Brooks Schur, invited comments, and you gave 10 comments that I thought, in a way, you didn't say don't do Medicare Advantage, which I guess would be my position, but you pointed out 10 serious flaws. And I thought maybe, first of all, is my summary of what you did accurate?
It's totally accurate. I think what I wanted to do, instead of saying don't do it, say to them, if you're going to do it, you got to do it a whole different way from the way you do it. And then it really wouldn't be doing Medicare Advantage. It would be doing a different type of healthcare coverage through Medicare. And so I just want to say that we started off by just highlighting that the three biggest Medicare Advantage plans have all been found to have violated many serious obligations they've had to the federal government, to Medicare, to Medicaid, to the VA. So we're not talking about a bunch of sort of cool and kind and gentle folk when we're talking about private health insurance, as we all should know. They've been found to be guilty of so many different frauds and misrepresentations and violations over the last couple of decades that we should all immediately be on alert that these people who are running the Medicare Advantage plans are not doing it, out of the goodness of their heart. They're doing it to make money every which way they can. So that was the context for why these overhauls of Medicare Advantage are so critical.
And I'm sorry to interrupt, Diane, but it's worth noting just very briefly what you wrote. You listed some of the violations, and I'll preface that by saying I think they've been very lax in enforcing violations. So for every one that the government enforced, there were probably many they didn't. That's my bias.
I couldn't agree more. I could not agree more. The tip of the iceberg. They don't have the money or the ability to identify so many violations. So for these insurers, it's the cost of doing business, and they know they're going to get away with a lot more than they're going to be caught for having done.
And you list United Health Group, which has the most Medicare Advantage enrollees, has paid nearly $600 million for 332 violations, 300 of which are for consumer protection related offenses in the last 22 years. Humana paid more than $77 million for 79 violations, 57 of which were consumer protection related. CVS, the third largest, $1.6 billion in penalties for 463 violations. And so it goes, and then you conclude, today the MA, Medicare Advantage plans, have too much incentive and opportunity for our abuse. That Senator Sherrod Brown and 5 other senators asked for answers about this, and 3 years later, CMS, Center for Medicare and Medicaid Services, has not addressed any of the serious issues raised. So you then go on raising, let me count them, 5 points that you think, as a starter, CMS should educate consumers about. And to me, this is very important because I think people are being lured into Medicare Advantage plans based on inadequate information and even misleading information. Would you agree with that?
100%. And I think it starts with the notion that both the government and the health plans put forward, and a lot of the mainstream media, that quote unquote, you can choose the plan that's right for you. And that's just not true. What we need to appreciate when it comes to Medicare Advantage, and really all health insurance, no matter where you're getting it, is that every health insurance product is different. And each plan decides what the barriers to care are going to be. So when they're going to allow care to be covered, and what obstacles you're going to have to get over in order to get that care. Each of them decides which doctors and hospitals you're allowed to see and which you're not allowed to see if you want to get covered for your care. They have so many, each of them decides how much you're going to have to pay out of pocket every time you go to the doctor or the hospital. And so all of those differences come together to determine whether actually you're going to be able to get the right care at the right time, or you're going to face financial and administrative barriers that prevent you from seeing the doctors you need to see when you need to see them. And you can't tell the difference. And anybody who really wants to make sure they get the care they need when they need it needs to be in the traditional Medicare program, because there, with supplemental coverage, you don't have to worry about cost, and there aren't these same administrative hurdles. You go to the doctors you want to see when you want to see them. You use the hospitals you want to see anywhere in the country. You don't have an insurer that is looking to maximize profits by withholding care from you, deciding when you get care, or coming between literally you and your doctor.
And so that's why one of the things you recommend, for example, is educate people about the high out-of-pocket costs of these plans, about their torturous prior authorization rules, and so on. You make a great point, Diane Archer, which is that people who are socioeconomically disadvantaged, whether they're from minority groups or with disabilities, serious health conditions, limited English proficiency, rural people, they disproportionately choose these plans because they cost less upfront in terms of premiums, which in a way, Medicare Advantage means giving the private sector an advantage over the public plan in terms of luring people in. But these are the very people you make, or I'm kind of interpreting what you're saying, but in other words, they're luring in the very people who will suffer the most disproportionately if and when they get sick or need care because of copays and deductibles, which make it hard for them to afford care, make them, these very same vulnerable populations, go without the care they need, referrals and prior authorization requirements and delays and denials of care. Not to mention that, for example, people who might have limited English language proficiency or might be older, might have some state of cognitive decline, what have you, going through these prior authorization, all these rules and regulations is hard for any of us, as some of us have learned. And so to impose even more complex rules on people who may be least in a position to navigate them, it seems to me like a horrendous kind of entrapment process.
Absolutely. It makes it really, the whole system involved in getting care in Medicare Advantage is a system designed to undermine health equity, because these hurdles are all the harder. They're hard for everybody to handle, as you've just said, but now people with cognitive impairments, people with physical impairments, people with lower incomes, are people with less English proficiency. All of those things just make it even harder still. And so we don't have the data, because the Medicare Advantage plans have been able to keep that from us. But you can imagine that high percentages of vulnerable people are skipping and delaying care in Medicare Advantage because of the costs and because of the administrative barriers.
And you go on to say, we propose a suite of 10 changes. I like that, a suite, an ensemble of 10 changes to improve health equity, reduce Medicare Advantage threats, enable appropriate oversight, minimize health insurer violations. Number one is change the way government pays Medicare Advantage plans, specifically so that they don't have a financial disincentive to cover care for people with costly and complex conditions. Right now, they make more money by not giving people who need care the care they need. Is that right?
Exactly. I mean, the system is insanely constructed, because the insurers get money up front, which they can keep if they don't spend it. So here you are, a Wall Street corporation, wanting to deliver good quarterly numbers for your shareholders, and you have this pot of money, and the less you spend, the more you can show in profits. And so what do? They delay and deny care inappropriately, some in excessive degrees, a lot, maybe even. We don't know. We don't have that hard data. We don't have the names of the ones that are the greatest offenders. But what we do know from the Office of the Inspector General is that it's a widespread systemic problem that these companies are inappropriately delaying and denying care. And you can understand why. And so what's even worse, as you think about it, is that the government allows them to design their plans in ways that make them unattractive to people with cancer and heart disease and stroke, who cost a lot of money. And even when those people are enrolled, it makes it hard for them to get the care they want. So they want to leave. And those tools seem to me to be absurd. You don't give these plans an incentive to keep money, or the ability to keep money that they should be spending on care. And you certainly don't allow them to design plans in ways that prevent people who need the care from getting it.
And you mentioned in your piece, Diane, that 10% of people with Medicare, or with the most serious conditions, account for 60% of spending, whereas 50% account for less than 5% of spending. So we know who they're going to go after. They're going to go after the 50% who look like they probably won't get really sick. If they do move into that other condition, because nobody knows what health problems they might face in the coming year, if they move into that other costly condition, they put them through such an unpleasant experience, really, that they drop them. And so it's not only again, I'm editorializing here, but you're welcome to disagree or whatever. What they're doing is not only incentivizing these plans to deny care to people who need it, but in a sense, they're incentivizing them to abuse people who need care so that they'll go somewhere else. Is that a fair conclusion?
They certainly have the tools to do just that. And we absolutely have good, hard data from independent researchers showing disproportionately high disenrollment from Medicare Advantage plans by the people who need costly care. And so what you're saying is not just hypothesis. The data actually supports the fact that people are leaving when they need costly care and going back into traditional Medicare. The problem is that they sometimes can't go back to traditional Medicare because they can't buy supplemental coverage, often when they're sick, and so they're locked into Medicare Advantage, and then they can't get the care they need. from those Medicare Advantage plans. And here, I mean, just one other point is that we allow these plans to design their provider networks, allegedly, because these plans know something we don't know about how to have a good balance of doctors and hospitals. But in fact, what they know is how to ensure that the doctors and hospitals in their network, protect their profits. And so a lot of them, for example, don't have cancer centers of excellence in their networks. Well, how can that be? How does Medicare allow that? Some interesting good news is that California and New York are just passing laws now that are requiring Medicaid managed care plans and ACA, state health exchange plans to have cancer centers of excellence in their networks. It's going to be just a requirement. Of course they should be there. That's where the best care is. But the Medicare Advantage plans don't have to include these hospital systems. And that's, again, a travesty. Anybody who's really sick doesn't want to be part of that. Yet They're being paid big top dollars to cover people with cancer.
Right, absolutely. And that gets us to your next point, which is changing the way these plans are paid to do the cost of service plus a reasonable amount for administration. And this gets, I don't want to get too technical in this conversation, Diane, but they're paid by, what they call risk-adjusted capitation. And basically capitation, think from head, capita, so per person, per head. Risk-adjusted, meaning if you're 65 in Medicare and no pre-existing conditions, whatever it might be, whatever rules they use, you're probably going to be less expensive. Certainly on average, that group is less expensive than, let's say, 85-year-olds, so they adjust the payments accordingly. But no matter how you calculate that risk-adjusted payment, that global payment for all care given, the incentive remains the same, right? It remains to give the least care possible. You may get a lot more for the 85-year-old, but you still make more money by giving them less care. So it seems to me what you're saying, it's more like they used to call it, a claims administrator, third-party administrator. They're basically saying, okay, if you pay $10,000 this year to treat enrollee A, then you get $10,000 plus a percentage for administration, maybe something to cover catastrophic costs or whatever. And that's it. You get paid for what you do. You have no incentive to be perverse. Isn't that what you're suggesting here?
Yeah, it's actually what large employers do. Right? It's what the biggest employers do. You pay the insurer for the care that they cover and a fee to administer it. But just to go back to what the risk adjustment piece, it's actually a lot worse than you've just described. So let's just go through it for a second because it's kind of interesting. So we talked about the fact that 50% of people spend, less than 5% of Medicare spending. They're getting, these insurers, these Medicare Advantage plans, about $12,000 for each of those people. So basically they're getting $12,000 to pocket to these people aren't spending any money on healthcare. So every person that they get who's healthy or not using the healthcare system, that's just basically money to them. It's a waste of money for Medicare because if you're in traditional Medicare and you don't go to the doctor, we're not spending money on you.
Right.
But here we're spending $12,000 on you. Now, risk adjustment means, as you suggested, giving more for people in poor health. But the way it's done by the government, and this is the game that's going on right now, is that the government allows these insurers to decide how healthy you are. And so it allows them to send a nurse into your home, and the nurse then finds a bunch of diagnoses to put next to your name. And as a result of those diagnoses, they get paid $50,000 for you or $100,000 for you. And guess what? You might not get one additional healthcare service, but because of those codes they've now entered next to your name, they're getting paid $100,000 for you. So that is an insane system. The system should be tied to what money they're spending on your care, and to allow them to inflate costs and expenses and charge taxpayers money when they're not even delivering additional services in many cases is just insanity. And it's also just so for our listeners who are in traditional Medicare, it's driving up the cost of traditional Medicare as well, because it drives up Medicare spending, and Part B Medicare spending has a premium associated with it.
Right.
So to the extent that it's driving up spending in Medicare, even though people aren't getting more services, right? Everybody with Medicare is paying higher Part B premiums. So it has an effect on the Medicare population, on taxpayers, on the Medicare trust fund. It is just the most absurd way to pay for healthcare services.
So millions of seniors are subsidizing the profits taken in by wealthy executives at a few insurance companies. That's what it comes down to. And seniors who may be living on $1,000 a month from Social Security or, what have you. So you also include Diane, the mind-blowing figure that CMS, that's the Center for Medicare and Medicaid Services, is projected to overpay these private health insurance plans an estimated $600 billion between 2023 and 2031. You're getting, you add a couple of years to that to make it the traditional Washington 10-year projection, you're getting up in the neighborhood of $1 trillion overpayment because of this upcoding, as we call it. And that's being subsidized, as you say, by everybody else on Medicare and by the country overall. It's amazing to me that in a Washington, D.C. that obsesses about every penny spent on, Social Security Administration or heating oil for seniors or what have you, that this figure isn't on everybody's lips.
Well, that and the fact that these companies are not effectively in jail for violating, their obligations to enrollees. As you said, their violations are probably far larger than have been discovered, but even still, here they are committing all kinds of fraud and violations, taking taxpayer money that they shouldn't be. And yet, instead of ending our contracts with them, we're handing them over $600 billion more. To do what? It makes no sense whatsoever.
Absolutely. And Diane Archer, of course, we're not going to be able to go into detail into every one of your 10 points, but several others that I thought were important. One is, you mentioned that you proposed that Medicare Advantage plans should pay providers, doctors, hospitals, radiology, whatever else, on a fee-for-service basis. Those that pay on a fee-for-service basis to use traditional Medicare's fee schedule, which is important for two reasons. And some, and again, I'm paraphrasing, and correct me if I'm wrong, but, that in some places, what these plans do is pay higher rates than traditional Medicare, in which case doctors may stop accepting Medicare, for example, or may give preferential treatment to these people in these plans, and makes harder for people with traditional Medicare to get care, drives up spending and so on, which costs everybody. Or they lower rates to providers, especially in the vulnerable communities where by policy, we want to make sure that if you're in a rural countryside, that there's a hospital that stays in business, right? If you're someplace where it's the only hospital around, and yet these plans can drive rates down, and the hospitals have a choice of either losing money by agreeing to these lower rates or going out of business. And so either way, they should not have this ability to game the reimbursement system, either at the expense of important providers or as a way of crowding out traditional Medicare. Have I summarized that pretty much accurately?
Yeah, I mean, I think the big point here is that Medicare has done a far better job than corporate health insurers at controlling healthcare prices. It could do still better. As we know, it should be regulating all prescription drug prices, but we now have a foot in the door there with the Inflation Reduction Act. For some drugs anyway. But the point here is that for doctors and hospitals, Medicare is better by far than private insurers at keeping prices fair and not extraordinarily high. But Medicare Advantage plans do not have to abide by those prices. They can piggyback off of them when they choose to, and they often do choose to. The risk here, though, is that they stop doing that. And as traditional Medicare shrinks in size and the Medicare Advantage plans have more power, they might find it's in their financial interests to pay providers more, to shift more costs onto their enrollees, and to make healthcare far less affordable for people in Medicare. And unless the federal government steps in and says, no, we have set prices for our providers. If you're paying them on a fee-for-service basis, you pay them the Medicare rate. Unless the government does that, we need to be very concerned that people with Medicare are increasingly not going to be able to afford to pay for the care they need.
Yeah, which is so critically important. I want to skip ahead now, Diane, to one that I think is really important, which is your proposal that the government standardize Medicare Advantage coverage rules and their cost-sharing plans and all of that, because this is where everybody, I've written up and told the story of having worked in this field for many years, how I still couldn't get a straight answer on what my own minor surgery would cost me out of pocket. It's just impossible to navigate this stuff. And as you point out, because every plan has different rules, every plan has, gimmicks and so on. And as a result, and because they can change at any time, as you say, and you document with links, these structural differences could be disabling and even killing people with Medicare prematurely, and CMS itself, the government itself, would not know, which I want to get to in a second. But so your proposal, have every plan operate by the same set of rules. Is that right?
Absolutely. And I should throw in here something that's important, which is that the American Hospital Association agrees with us on many of these points. And they're not usually the people who we're seeing eye to eye with, but their letter to the Centers for Medicare and Medicaid Services echoes a lot of what we're saying in terms of a lot of them are in jeopardy because of the way that the insurers are each doing their own thing and not paying them appropriately. And they have to go, each hospital has to go through different hoops with different insurers, and that costs them time and that costs them money, and that drives up hospital costs even more. And so for a whole host of reasons, starting with it's going to reduce administrative costs for everyone if there's one standard set of rules about when prior authorization is allowed, what the insurers pay, when they pay it, and what is medically necessary. That would help enormously. It would also help from the perspective of oversight, because right now, because you see one Medicare Advantage plan, you've seen one Medicare Advantage plan, because you can't look across them all and say, this is what's going on in all of them. It's impossible for oversight to happen effectively. So for all kinds of reasons, we need that standardization. That's not something anybody is talking about, but they need to be. And that's the way it's done. A lot of people are thinking probably right now, well, in Europe, there's private insurance, and it works really well. Why are you saying, it can't work here? And the answer is, in Europe, it's all standardized. That's how it works. The insurers aren't paid more if they denied care. They're not able to decide what the out-of-pocket cost is going to be for a particular procedure. It's all fixed. They are simply following the rules that are set by their federal governments and paid an administrative fee to do so.
And, Diane, in a past life, many years ago, I used to audit federally certified HMOs. And so as it was only one of multiple things I did, but I can tell you that an audit is complex if there's no standard set of rules to go by. And it involves, kind of hands-on and judgment, that kind of thing. But it amazes me that even the easier, more standardized types of audits, taking batch files from these plans and running them, that those don't get done. And it seems to me that, which is why your next proposal is ensure appropriate oversight of these plans. I mean, you pick a crazy number. Let's say that the government had to spend $750 million to properly audit these things, which I think is very excessive. But just pick a number, right? That would be 1% of the projected overpayments over an 7-8 year period. So it would be an incredibly wise, judicial, and that's even leaving aside the lives lost, the people hurt, which is of course much more important of the two things, than the numbers. But just on a dollar and cents scale alone, it is insane that we're not doing that.
Yes, the government is supposed to be doing it. I think there's I think it's the GAO, the Government Accountability Office, that has said that some audits as far back as 2011 have yet to be conducted. So it is insane that CMS is not up to date on its audits. But the reality, I believe, is that even if it did these audits, at least if it continues to do what it has been doing, it wouldn't really do enough for us because it doesn't have the tools to identify all the different violations that could be committed by these Medicare Advantage plans.
Yeah, it makes complete sense. And because we're running out of time, I will say, your last suggestions: do not assume value in these plans, since value cannot be measured. That's, you document why, rethink these networks altogether so that their current incentives are redesigned and put in alignment with public policy. Give people better information because they don't have good information now. And lastly, and maybe we conclude to that, level the playing field with traditional Medicare and ensure health equity and Medicare Advantage. Maybe we can just close with if you have a couple thoughts about that. I
do have one thing I want to say to folks, which is that if you hear the term value-based care, ignore it. It is Orwellian. There is no data, so there's no value. And the notion that Medicare Advantage offers anything other than value-less care is just false. Traditional Medicare is probably higher value care. I mean, no probablys about it. It's definitely higher value care because we know it's more cost effective, and we know that the quality of care it delivers from an access to care and a health equity perspective is much greater. So if you want value in your care, you choose traditional Medicare. And traditional Medicare also offers you the data so that you can be looking at things. Medicare Advantage is value-less care.
And that's very well said. And I look forward, I hope for a day when the pernicious influence of profit taking is taken out of Medicare altogether so that it can be what it was meant to be, which is social insurance for the good of all.
I do too, Richard. Onward towards that goal.
Onward indeed. With Diane Archer of Just Care USA. You can find this and other writings by Diane at justcareusa.org. Thanks as always for your terrific work, and thanks as always for coming on the program.
Great to see you, Richard. My pleasure.
Great to see you too. And we'll be right back after this. I'm Richard RJ Eskow, and this is the Zero Hour.